So we begin the Smt Puspa Rani Dash Memorial Oration. I would request our President and Secretary to please stay on the stage. Dr. Otishpa will preside over the session as before. And I will hand over the session to Dr. Debashish Dash, who is our moderator as well as the Honorable Secretary of the OSWB. Over to you, Debashish Dash.
A very good afternoon to all of you. We are going ahead with Smt Puspa Rani Dash Memorial Oration. May I invite our chairpersons for the session today, Dr. Pushpita Shahu ma'am, please. Our co-chairperson today, Dr. Arup Chakraborty. May I have our scientific committee chairman, Dr. Rupak Kanti Biswas, on the dais, please. At the initial stage, may I introduce the orator today, none other than Dr. Santosh Honavar, the man we look forward to for our academic brilliance. I'd like to introduce her once more for the oration today. Dr. Honavar received the residency training in ophthalmology, followed by senior residency in ophthalmic plastic surgery and ocular oncology at the RP Center for Ophthalmic Sciences, AIMS, New Delhi. Okay. Sir, may we have you on the dais, please, sir, as I'm introducing you, sir. He further trained in ocular oncology and was mentored by Professor Jerry Shields and Professor Carol Shields at the Wills Eye Hospital, Philadelphia, in USA. Where do I shift? Where is the... It's not moving. He thereafter established the ocular oncology services at L.V. Prasad Eye Institute, Hyderabad, the first of such facility in the country. He was the associate director of LVPEI, headed by Patient Care Services, and established the residency programs there. Dr. Honavar currently heads the Department of Ophthalmic Plastic Surgery and Ocular Oncology at the Center for Sight, Hyderabad. The Eye Focus PG education program run by him is hugely popular amongst ourselves. As the editor of the Indian Journal of Ophthalmology, Dr. Honavar was responsible for its soaring impact factor. He is currently the Honorary General Secretary of the All India Ophthalmological Society. With ocular oncology as his research focus, he tops the Stanford list of researchers of the highest impact in India. Some of the major awards and honors to his credit include Cornel Rangachari Gold Medal Award by the AIOS, the youngest recipient while he is still a resident. Dr. Siva Reddy International Award by the AIOS, Shanti Swarup Bhatnagar Award by the Government of India, Jerry Shields International Award by APAO, the first Indian ophthalmologist to receive the Lifetime Achievement Award by the American Academy of Ophthalmology, the highest award of the Royal College of Ophthalmologists, UK, its honorary fellowship. With that, may we invite you, sir, for the oration today. We highly appreciate your academic background, and I think it is an honor for all of us to initiate the program. With that, I'd like to hand over the oration medal, by our President, Dr. Rotish Chandra Pal.
I thank OSWB for this honor and wonderful opportunity. Thank you for your very kind introduction. No, so I'll introduce Smt Puspa Rani Das very briefly. She was supposed to be not an ordinary lady, extraordinary in every sense of the word. From a very young age, she had interest in music and a keen sense of music, and was honored Bhadya Ratna from Calcutta University. She then married an ophthalmologist, Dr. S.K. Das, a prolific eye surgeon, and she dedicated her life to nurturing a close-knit family of 4 children. And not just that, she was instrumental in building the Eye Foundation and Research Center in 1997 to cater to complicated posterior segment cases. Her family remembers her with fondness and love, and her kind words still echo among them. And it's a privilege to deliver an oration in her name. And I'll be speaking on something which may be relevant to you in your day-to-day practice, ocular surface tumors. How do we manage or how do we deal with them once you see them? Ocular surface is a very wide area. In fact, under the lids, palpebral conjunctiva, phonacial conjunctiva, bulbar conjunctiva, superior, inferior palpebral conjunctiva, everything is ocular surface. Such a wide area, including the caruncle. So in between this wide area, you would see something that may pop up once in a while in your clinical examination that may be a tumor. But what is important to know is that all these are not benign tumors. In the middle of these benign tumors would be hidden something very sinister. 50% of ocular surface tumors are actually malignant tumors. And if you look at the largest series that are published anywhere in the world, you will find that the reported local tumor recurrence rate is as high as 20 to 30%, which is absolutely not fair to the patient. And also, every recurrence will give a higher risk of regional lymph node metastasis and systemic metastasis. So there is a way that we can avoid all this by combining our already existing excellent surgical skills with very few basic oncological principles. We are all very good microsurgeons, that's why we are ophthalmologists, and if we combine those surgical skills which we already have along with the understanding of oncological principles, then you can actually reduce this 20% recurrence rate to less than 2%, that too in syndromic patients where you cannot avoid recurrence, such as HIV seropositive patients or patients with xeroderma pigmentosum who may still have local tumor recurrence, but in all others we can avoid. Now, what are these oncological principles? Number one is to accurately determine the diagnosis and extent of the tumor before you even try to manage it. Diagnosis is important. Not to use topical therapy, which is the current trend, 5-fluorouracil or interferon or mitomycin, until we are sure of the diagnosis. Whenever we plan surgery, we have to achieve edge and base clearance. If you leave any microscopic residual, then that would attract local tumor recurrence. If at all you find that on pathology that the part of the tumor is left behind, then you have to provide appropriate adjuvant therapy. So adjuvant therapy should not be guided by guess, but it should be driven by histopathology. Screen for regional lymph node metastasis, which we often forget to do, and use target therapy very judiciously. Diagnosis is evident because these tumors are actually looking at you, begging for a diagnosis. They are staring back at you, and we don't have a chance of missing them. But there are sometimes confounding clinical situations. Like any of these 4 patients may be sitting in front of you when you go back to your clinics on Monday morning. How do we know which one is an EVIS and which one is not an EVIS? These 4 pictures are very similar. All these are young individuals. We have a clinical checklist. Interpalpebral bulbar conjunctival location, more than 80% of nevi are in that location. Variable pigmentation, tan brown to dark brown, all shades of brown. No corneal epithelial invasion, nevi stop short just at the limbus without going on to cross over to the corneal epithelium. They don't have episcleral fixation. You can move this with a wet cotton tip deplicator on the ocular surface. Under slit lamp, you will find that they're actually moving on the episclera, so they're not fixed to episclera, and they don't have intrinsic vascularity. This feeder vessel is pardonable, but they don't have intrinsic vascularity within the lesion. These are all clinical characteristics of a nevus as opposed to a melanoma. But if you still have any doubt, you can bring in these modern tools, which are anterior segment imaging. If you find microcysts, these are microcysts, or large cysts, which are called macrocysts, within a nevus, nevi are supposed to be spongy, melanoma is solid, then you find that this is indeed a nevus. This is a clinical confirmation of your diagnosis. It comes handy in a patient like this 11-year-old child of very high-strung physician parents who brought this child with having noted a fleshy pink lesion on the ocular surface just about 2 weeks ago. Probably they noticed it just about 2 weeks ago. It's fleshy pink. It does have some vessels within it. It has a feeder vessel. It has crossed over the cornea just about 1/4 millimeter. Now, how do you know what it is? Simply do an imaging and you find microcyst. So it's a amelanotic nevus that this child has, which is possible. As the child get into the teenage years, it may get more and more pigmented. So we have a diagnostic tool which we already have in our offices, anterior segment OCT, which you can apply, or UBM, which you can apply to diagnose a nevus from a melanoma. When a nevus transforms into a melanoma, the risk of which is 1 in 100, you can actually know by doing, of course, a clinical evaluation, but also by imaging. This child always had this nevus. He went out of the city for about 6-7 years for higher studies and came back with a new lesion that has popped out of the existing lesion, which is jet dark brown with some fleshy component, lot of subconjunctival vessels and hemorrhages. And when we did imaging, we found 2 areas, the solid and cystic. Cystic area corresponded to this existing nevus and solid area corresponded to the new growth. On histopathology, you find that there is a solid area which is dark blue, which is melanoma. This is a zone of transition and this is still a nevus. So whenever a nevus loses its cyst and it becomes much darker brown and more solid, then it has transformed itself into a melanoma. So we have a clinical sign already. Now about ocular surface squamous neoplasia, we have a triad of signs which will differentiate one from the other. Keratin, which has good sensitivity. So if a conjunctival lesion, it may look like pterygium pingicula inflammation infection to you, but has a spot of this white material, which is keratin, which is nothing but a byproduct of epithelial cell turnover. That means that you're looking at something which is metabolically active. Most likely, it may be a tumor. You have to deal with it with all respect. Whenever keratin is accompanied by abnormal vascular pattern, which is all these abnormal blood vessels that this has, then your diagnostic sensitivity and specificity becomes much higher. Just add a 1 rupee test, Rose Bengal staining. When you have abnormal vascular pattern, Rose Bengal staining plus keratin, then you're as good as the gold standard. 97% sensitivity, 98% specificity, very good predictor that it is ocular surface squamous neoplasia. So if you have a conjunctival lesion that may look like anything, but it has a spot of keratin, has abnormal blood vessels and also stains with Rose Bengal, then you should treat it with due respect. It most likely is ocular surface squamous neoplasia. So diagnosis is very easy. And if you still have any doubt, again you bring in anterior segment imaging. This is high reflective and hyperplastic. This whitish is hyperreflective corneal epithelium as opposed to normal corneal epithelium, which is gray, 70 micron thick, as opposed to this about 500 micron thick. So hyperreflective, hyperplastic corneal epithelium, which ends suddenly with a snout without any gradual zone of transition, is a clear-cut sign of ocular surface squamous neoplasia. This triad of signs was described by Carol Karp, and it's a very good tool that you can use to diagnose one from the other. Now about treatment. When you have a patient who has ocular surface squamous neoplasia, there are many ways of treating it, one of which is topical therapy. We have chemotherapeutic agents which are 5-fluorouracil and mitomycin. We also have immunotherapy, which is interferon alpha 2b. Now, interferon is currently not easily available in India, so we still have gone back to 5-FU. Mitomycin is a good second alternative. But when we have interferon, when it was available, we used to use it in 3 formats. One is immunotherapy to completely eradicate the tumor, immunoreduction to reduce the size so that we can do less extensive surgery, and immunomodulation where we can control the development of new tumors by modulating the local immunity of the ocular surface in HPV-induced malignancies. So what are the indications? Small tumors like this go away with about 6 weeks of treatment of topical therapy, whether you use 5-fluorouracil, mitomycin or interferon, it really doesn't matter. Doses are all known. Small tumors, again, completely gone. The most important indication would be corneal ocular surface squamous neoplasia. Why is that? That's because corneal OSSN would leave a subtle scar if you treat it with surgery primarily. This is an example where my cornea friend had done a biopsy from this location. He established the diagnosis and sent the patient over to me. I treated this with topical therapy. Tumor completely went away. This is the picture that I'm showing 3 years later. In the exact area where he had done a biopsy, you see a very subtle corneal scar. which means that if you were to do primary excision in this area, pupillary axis possibly would have some corneal scar left, so vision may not have been 6, 6, and 6. So in a patient who has pupillary axis involvement, definitely you would want to use topical therapy. Or in a complicated graft like this is a third graft in a patient with xeroderma pigmentosum. Prior two grafts had failed, the other eye was thiazical, and in the graft-host junction there is a ocular surface squamous neoplasia, which people with xeroderma pigmentosum are known to develop. And here again we use topical therapy, and this graft did not get rejected, or there was no graft failure, graft survived, and the tumor went away. Or if the tumor is more than 6 clock hours in limbal extent, because if we excise limbus to that extent, then there is a possibility of limbal stem cell deficiency leading on to conjunctivalization of cornea. So if you want scarless healing, then you should use topical therapy in tumors which are as extensive as more than 6 clock hours, or a diffuse OSSN involving almost the entire ocular surface. Of course, you can do surgery. If you challenge somebody, they can do surgery, but what are the complications of surgery? Scarred ocular surface, conjunctivalization of the cornea, limbal stem cell deficiency, possibly vascularization of the cornea. All that can be avoided by topical therapy. 3 months of interferon is what that was required in this particular patient. So these are the indications. Why I'm stressing on these indications that if there is a tumor like this, which is very high and tall with a narrow base, then topical therapy is unlikely to work. All these are selected patients, specifically selected for topical therapy on the basis of their clinical configuration. So you should choose patients who have a diffuse flat lesion rather than using a high elevated lesion. Immunoreduction is a concept where a tumor as large as this can be reduced to such a small size by using topical therapy. And why does this happen? OSSN is a tumor of the limbal stem cell. So if this is the epicenter, that would be invasive squamous cell carcinoma, around which would be a zone of carcinoma in situ, severe, moderate, and mild dysplasia. When you use topical therapy, all this dysplasia and carcinoma in situ go away, and what is left is the invasive component which you finally excise. So that is the concept in which chemo reduction or immunoreduction is based. So you erase part of the tumor which goes away with topical therapy, and surgically deal with only that remains following topical therapy is the concept. In patients who have diffuse OSSN like this, where exentration is imminent, you can still try to salvage by using injection interferon, along with topical therapy, of course. So 50% is the success rate here, but 50% of those who benefit have their eye and vision saved. When not to offer topical therapy, when the diagnosis is in doubt, this may look like OSSN, but when we flip the lid, there is widening of the lid margin, rounding of the posterior lid margin, meibomian gland orifices are all lost. So this is pagetoid sebaceous gland carcinoma where topical therapy will not work. When we're not sure of the depth, again, somebody used topical therapy in this patient, tumor was already in the sclera. You can see that it continues to progress, there is no resolution. So we should be aware of the depth of the lesion, and when you're not sure about patient compliance, again, you should not use topical therapy. So all these patients select themselves out for surgical intervention. There lies our surgical skills. So whenever we excise any tumor, any ocular surface tumor, what is important is edge and base clearance. Edge is easy to evaluate. Now I know that this is the edge of the lesion, right? This is the visible edge, but beyond that there is conjunctival thickening, but I roughly know that this is the edge of the tumor, beyond which I should go for 4 millimeter clearance. I know where to make my incision. But what about the base? How do I know how deep it is? I can only guess. Slit lamp will not tell you because the tumor is opaque. UBM may tell you, but UBM is not precise. Or ASOCT will have problems because the tumor, if it has keratin, ASOCT will have a shadow artifact. So you are not very sure about the base. But you still try by looking at the imaging, you try to determine the base, and you're pretty sure at the time of surgery if a patient does not have keratin, where the base is. For example, this patient has tumor right in the conjunctiva, this bubbly layer cystine, and so your plane of dissection is going to be episcleral. You already know it. But when you don't know about the base, there lies the problem. This patient also has a corneal OSSN, but by doing UBM, we have realized that this is a normal corneal stroma. This stroma is splayed and it is hyperreflective. So this patient has full thickness corneal stromal involvement already. So excision of the tumor is not going to help him. What will help him is complete removal of the cornea with keratoplasty or plaque brachytherapy. So by looking at the base, we know what treatment to perform. And a detailed conjunctival diagram. This diagram is very essential because once we give peribulbar block, conjunctival chemosis will happen, and you may not see subtle component of the tumor that you saw on slit lamp evaluation. So we draw this detailed diagram not for every patient, but for complicated patients like this, where the tumor is multifocal, and take it with us to the operation theater so that we know exactly what to excise and not to leave any part of the tumor behind. Surgery itself is very simple. You delineate the tumor, and then beyond 4 millimeter of the clinically visible edge of the tumor, you make a conjunctival incision. Since I have an oculoplasty background, I use RF electrode, but otherwise you can use any instrument of your choice. Excision of the tumor using monopolar RF electrode, that's relatively bloodless. Then you lift the free edge of the tumor and dissect at the base. The idea is to reach the limbus from the conjunctival surface. This dissection is again bloodless with RF electrode. Cauterize the feeder vessels at the base. Then you lay the tumor back, apply absolute alcohol to the leading edge of the tumor. That is to precede alcohol-assisted keratoepithelectomy of the corneal epithelial component. The epithelium is scrolled off towards the limbus. So we are reaching the limbus not from the conjunctival side, but also from the corneal side. And finally, you excise the tumor off the limbus, because OSSN is a tumor of the limbal stem cells. So you have to do necessarily a very superficial limbectomy when you excise it off the limbus. So we are reaching the limbus from the corneal side. Then begins the excision of the limbus. You simply use a crescent knife and excise it off the limbus. Under visualization, what you excise should be visible. You should not leave a part of the tumor behind. And if you find during this process that part of the tumor is slightly deeper, note that area and do cryotherapy. This is excision edge cryotherapy, which is mandatory. Drape the excised edge of the conjunctiva over a 3 millimeter cryoprobe and freeze it twice over. Double freeze thaw cryotherapy. This will guard at least 4 more millimeter of conjunctiva against local tumor recurrence twice over. So you don't cryo the sclera, etc. You simply cryo the conjunctiva. You see the end point already because it is posterior to anterior cryotherapy. Exactly where you had noted a deeper component of the lesion, you cryo that as well. You can do that for about maximum 3 clock hours, not more than that. And finally, repair the ocular surface either by using a conjunctival autograft or even an amniotic membrane. I'm fond of using amniotic membrane. It's glued onto the ocular surface using a tissue glue. So a very simple surgery, absolutely simple, but 3 points I have made here. One is that 4 millimeter clearance, locate the edge very carefully, excision edge cryotherapy, and alcohol-assisted keratoepithelectomy. If you adapt these 3 additional parts to your surgery, which is already excellent, then you can have less than 2% local tumor recurrence and very good functional outcome. Now, beyond surgery, patients who have scleral invasion, earlier we would enucleate them or exenterate them. There was no other choice of treatment. Now we don't do that, we use plaque brachytherapy. Now plaque can be used secondarily. We excise the tumor, get the histopathology, pathologist tells us that base is positive, then we apply plaque, that is secondary plaque brachytherapy. Works very well in patients who have scleral extension like this with good visual recovery. But for patients who have a melt already, like this patient you can see has stromal melt, how can you excise it? You cannot excise it without compromising the tectonic integrity of the eyeball. So where we do a small biopsy here, confirm the diagnosis that it is indeed OSSN, which is required for medical legal purposes, then we apply plaque right on top of the tumor. That's called primary plaque brachytherapy without any surgery at all. And that also works very well. So primary plaque brachytherapy can be used for compromised situations. And this is a patient where there is melanoma, we know that already, and then there is a scleral component. This nodule is easy, but the scleral component is difficult because it's nearly full thickness scleral invasion. There we again used primary plaque brachytherapy. This is a situation where there is multifocal recurrence of melanoma by in a patient with PAM. Multiple surgeries done elsewhere, and he has intraocular extension as well. You can see the ciliary processes here. But the patient has 6/6 and 6 vision, and he's very adamant that he wants to have this eye and vision. So there we excise the tumor. I'll skip the video. And we use rotational plaque brachytherapy technique where we use the same plaque in multiple locations to cover the entire base of the tumor, and the patient is doing well 3 years later. Plaque brachytherapy has over 90% success in eye and vision salvage, and that's something which we are very happy about because that gives us an additional scope for eye and vision salvage. In patients who have intraocular extension, this young individual had intraocular extension of ocular surface cumulus neoplasia with retinal and choroidal detachment, but again he wanted to have his eye preserved. So there we design a stereotactic radiation portal. This is how we radiate this. This was chemoradiation with 5-fluorouracil as the radiosensitizer. And you can see that his retinal detachment, choroidal detachment settled down. And on B-scan, you find that the intraocular component is gone. On UBM, you can see that the ciliary body component is gone. These are, of course, in desperate situations. We don't do that every day. But in patients who are very keen that their eye should be saved, we still have a way of saving these. This is on MRI. You can see that it's resolved. But for patients who are advanced like this, we still have to do orbital exentration. Beyond surgery, we have a protocol of providing adjuvant therapy, and currently we have target therapy as well. I was showing in another session where we have conjunctival lymphoma, part of which can be excised, but the part that is beyond excision, which is around the eyeball going posteriorly into the orbit, we had radiation earlier. Now we use a local targeted therapy, which is rituximab injected into the periocular location. 6 injections, 3 weekly apart, can take care of this patient without radiation. And for conjunctival melanoma, we had a mutational spectrum and the drugs already worked out. There are reports that are appearing in the literature using pembrolizumab, nivolumab, and this was my experience in a patient who had nivolumab. This is an expensive drug, but this patient had regional lymph node metastasis, for which he got approval from the insurance for use of nivolumab systemically. 3 months after starting nivolumab, his conjunctival component also dramatically regressed, which is a case perhaps for using these agents in patients who are inoperable or not qualified for surgery in any other sense. So there is a situation where we can use targeted therapy for conjunctival lesions. So in conclusion, I would say that adherence to oncological principles optimizes eye vision and of course life salvage in malignant ocular surface tumors. Thank you so much.
Excellent, sir. We have enjoyed every bit of it. Thank you so much. With that, may I request our Vice President, Dr. Arup Chakraborty, to present the award plaque to Dr. Santosh Honavar. And may I request our past President, Dr. Pushpita Shahu, to present the certificate and the bouquet to Dr. Honavar. With that, may I hand over to Dr. Rupak Kanti Biswas to give the thanks and photograph is there.